Hey guys, can you hear me?
Vinky.
Oh, you guys are having too
Vinky,
much
you're
fun
on.
here. We've been working hard here. So let's
Yeah.
present this case. I was waiting for Dr. Raja to finish, but I think I got squeezed out. Let's present this case quickly. Give me 5 minutes, and then we'll cut 5 minutes off for lunch. Eat very little. So this is a 74-year-old male. As you can see, severe comorbid conditions, EF30, bilateral vein ablation, smoker. Basically came to us with multiple prior interventions, was actually referred by an interventionalist as she developed a left great toe ulcer, severe rest pain. She's had multiple stents and stent procedures in both legs, I think, and interventions too. So she came to us for possible bypass limb salvage, and you can see with an ABF, I think 0.47, 47, and obviously occluded with monophasic flow going down, 80 being the main runoff. So obviously we thought of doing a bypass, but no vein, and I'm not a huge case of, taking arm vein unless my hand's really forced. And so we actually put her up for PTAB. I know PTAB has become a lot of discussion during this meeting, and Dr. Bernardo, I remember doing a PTAB at CRT, and it can be troublesome. So here's the angiogram. Let's go quick. So that's the right leg. So right leg also has severe disease. Go to the next. Let it play first. That's her distal runoff, single peroneal going to the foot. On the left side, she has a flush occlusion of the SFA. Yeah. Next one is a flush occlusion of the SFA. And you can hardly see a nipple to the SFA. Go to the next one. Distal, it reconstitutes actually pretty well. And they tried to open these stents multiple times. And you could see that they were not successful. Look at the numbers. Okay. And so distally, you see she's got good collateralization. And then show me her foot runoff. She has a single 80 that actually goes to the foot with a diseased peroneal too. Can you see the numbers? No, you're showing me all. Come on, this. Number 11. Can you see the number? Number 11, you can see. Again, sluggish to the foot. But you can see peroneal and the DP going down. Okay. So we decided to do PTAB. And of course, you can discuss this at the end during lunch. And we went in proximal. We found the nipple of the SFA. And you can see the stent. We ballooned that SFA proximally to create a channel. Then we got into the vein, and we could not get venous access. So again, if you look at her on ultrasound, PT was really bad. So we actually punctured the saphenous just to see where the femoral vein is. And we did without vein access. So we entered there. Get back in. Next one.
Vinky, we see a flow from. So where was that the access then for the vein?
Saphenous. I tried to go from the saphenous into the deep system, and then I wasted significant time on this. And then we decided to do it without any vein access. And so we entered proximal. We entered re-entered distally. So the next one.
Is that the end of the final shot? Yeah, that one.
The number then.
Yeah, 15 was the last.
So the key was, of course, to balloon aggressively the proximal entry and re-entry site,
This is the last one we just did. Yeah, that's 15. Yeah,
So,
yeah, 15. Yeah, this is 15. And then the last one's our final shot.
yeah, so I used serenator balloons here, and I think there was some discussion about cutting and scoring balloons. The key is to really balloon these two entry and re-entry sites very aggressively.
Here's the balloon.
And so that was the balloon. You can see that little waist over there where we re-entered just above the patella. Go to the next one. And just show them the final pictures. I was going to show this step by step, but I think we've talked and basically did a lot of talking on PTAB today. And I think it's a good armamentarium to have. See, you can see the profunda is very clear. Initially, I thought I may have indented the profunda, but the profunda is well away. The takeoff is higher. The upper 2 millimeters of the stent are bed spring. See? So we didn't. And then you can see the
Yep.
entire SFA, the stents are filling nicely. Go down.
Yeah, the nice thing, Vicky, is a very good landing zone in the
Yeah,
distal
yeah.
pop segment. Very
Yeah,
good
so we
landing
entered,
zone.
and now we have, you can see the AT and the peroneal filling up nicely. There was some disease in that peroneal TPT trunk area, but we'll touch that up later on. And I think this is good enough because the wound is basically the great toe. Go to the foot picture, please. Yeah, that's the foot. And you can see it fills up very nicely. The plantar arch fills up too. The PT fills up too. So I think we're okay for
yeah.
now. So
Very nice.
so PTAB is also a good option. And again, Nelson, you know very well where exactly PTAB fits into your practice and where into the algorithm of the SFA popliteal revascularization where PTAB is an option. So as interventionalists, I think we should have all tools at our disposal. And I think new technology should be tried out, evaluated, and then finally embraced. So thank you so much, guys. I think it was a great session this morning, and I will see you at lunchtime, and then we'll go on to the afternoon session. Thanks, Nelson. Thanks, Anahita.
Thank you, Vinky.
You're welcome. Take care, guys. We'll sign
Yeah,
out from
thank you,
here,
Vicky.
and I want to thank everybody over here.